Good morning. Thank you, Dr. Grover. I'll be addressing one more prevailing controversy in oculoplasty and oncology, that is whether to conserve or exentrate. The primary goals of managing a cancer remain salvage of life, and if that is possible, salvage of the organ, that is the eye, and only when that is possible, salvage of vision. When we talk about specific indications for orbital exenteration, orbital retinoblastoma, rhabdomyosarcoma, adenoid cystic carcinoma of the lacrimal gland, and ocular surface or eyelid tumors with orbital extension remain on top. With that, despite us having not violated the primary goal of salvaging life, if we were to do only orbital exenteration as the primary therapy in these patients, we have death up to 75%. That's by the literature. So can we turn this around and say that can we conserve the eye and vision while optimizing life? Is that possible at all? Multimodal treatment comes to our rescue. Multimodal treatment is nothing but a combination, a sequential scientific combination of surgery, radiation and chemotherapy delivered appropriately. We have come to realize that orbital exenteration or radiation alone in these life-threatening conditions may not result in reduced incidence of systemic metastasis, having learned from CA breast, small cell carcinoma of the lung and renal cell carcinoma where this modality has been specifically used. In orbital retinoblastoma, primary orbital retinoblastoma, where the child presents with an orbital tumor without prior treatment, or secondary when there is orbital recurrence following enucleation, there is 75% mortality with orbital exenteration alone. In such patients, we currently begin with high-dose chemoreduction with a combination of carboplatin, etoposide and vincristine and perform enucleation after the orbital component has reduced and the eyeball has gone into athysis. This is followed by orbital external beam radiation and continued chemotherapy for 12 cycles. Let's look at the results. You can see that this large orbital mass has reduced to a classical eye, at which time you would actually surgically intervene and go on to provide further treatment. One more example of similar situation. This is how the orbital component regresses. This is the orbital component completely regressed and the eyeball has gone into a comfortable athysis from this situation to this situation following 3 cycles of chemotherapy, at which time you would do surgery and go on to give further treatment. This is an example of a child who has completed the entire protocol, has had 3 years of follow-up following that, wears an eye prosthesis and goes to school. Even in situations which are earlier considered unsalvageable, massive optic nerve extension right up to the orbital apex, where despite doing deep lateral orbitotomy and a deep bone cut, you wouldn't be able to get a clear margin there right at the orbital apex. Currently there is hope. You can see that this large optic nerve extension has reduced now following neoadjuvant chemotherapy, and this child now is available for surgical intervention followed by stereotactic radiation. There are, however, situations where orbital exenteration may be necessary, but then that has to be preceded by chemoreduction. This is an example where you can see that massive orbital extension has reduced considerably, but there is still presence of orbital residual, hence we have to perform orbital exenteration. This is an example of a secondary orbital retinoblastoma following enucleation. The implant looks black in MRI, but this is a CT scan. You will see that the implant has nicely settled back into its position following multimodal treatment, and the child can wear an eye prosthesis. So, in a series of 30 unilateral retinoblastoma with orbital extension, we had 94% survival considered, comparing back to 75% mortality, which we had earlier. That's a magical relief. In rhabdomyosarcoma, we have learned from intergroup rhabdomyosarcoma studies, which has shown major success with multimodal treatment. Currently, we perform incisional biopsy or debulking as appropriate without compromising on the functional aspects of the eye and go on to give chemotherapy. Now, which protocol to use is again guided by intergroup rhabdomyosarcoma study, where we classify rhabdomyosarcoma as low, intermediate or high risk groups depending on the orbital residue and also taking histopathology into consideration. You can see that this is a patient with massive orbital disease. This patient has been debulked, conserving the inferior rectus muscle around which the tumor was wrapped around. Following that, we administer chemotherapy with a combination of VAC and IE for 3 cycles and sandwich radiotherapy in between and provide 3 more cycles of VAC IE following radiation. And you can see that the eye is nice and conserved. There are no side effects of radiation in this patient.
enjoys 6x vision. Even larger tumors, larger abdominal sarcoma can be conserved with eye salvage. All that is residual here is mild doses that can be surgically taken care of with this management modality with about 96% survival. In adenoid cystic carcinoma of the lacrimal gland, where earlier there used to be major risk of mortality, we have come to use the same protocol. This is a patient who has had adenoid cystic carcinoma of the lacrimal gland. Following completion of therapy, he has 20/20 vision and the tumor is all gone. Even in a rare situation of a child with adenoid cystic carcinoma, you can see that this child had massive disease, bone disease, as well as extension into the superior aortic fissure, earlier considered incurable. Now following multimodal treatment, you can see that the eyeball has settled into position and the bone disease has all disappeared. We can use even interstitial radiotherapy in such situations. This is a patient with adenoid cystic carcinoma where we implanted silicone tubes at the time of surgery and delivered after-loaded interstitial radiotherapy to our advantage. With this, we have 90% survival in patients with adenoid cystic carcinoma of the lacrimal gland. The last bit about sebaceous gland carcinoma, specifically those who have orbital extension and also regional lymph node extension, that completely goes away with neoadjuvant chemotherapy, and patients from being ready for excision earlier now are amenable to local excision. Again, one more example of sebaceous gland carcinoma following neoadjuvant chemotherapy, now amenable for local excision, another such example. In sebaceous gland carcinoma, we have 90% survival despite lymph node positivity. So comparing the results of the management before multimodal therapy began, we have a major success from 75% death to 95% survival in orbital RB. Rhabdomyoid sarcoma again improved survival. So is the situation with adenoid cystic carcinoma of the lacrimal gland and sebaceous gland carcinoma of the eyelid with orbital extension. So in conclusion, I would like to say that multimodal treatment with a combination of chemotherapy in adjuvant or neoadjuvant mode, surgical excision, judicious external beam radiotherapy as stereotactic variant can improve eye salvage and minimize the risk of local tumor recurrence and also systemic metastasis. Currently, we can conserve yet improve eye salvage, life salvage. Thank you so much.